Good morning, and welcome to our 5th annual Patient Symposium, Pancreatic Cancer, Your Family, Genes, and Cancer Risk. We're delighted you could spend this morning with us and listen to the current state-of-the-art technology and information regarding pancreatic cancer risk. Before we get going, my name is Kristen Shannon, and I am a genetic counselor and the administrative director for the Center for Cancer Risk Assessment at Mass General Hospital. I'd like to just go over some housekeeping tips before we get going. First of all, you are in listen-only mode and the chat is disabled. If you would like to ask a question, please click on the Q&A icon on the bottom of your screen. Only the presenters will see your questions and you can make them anonymous if you would like. The speakers will be answering questions at the end of each talk and we'll have additional time for questions at the end of the conference this morning. Finally, this conference is being recorded and will be posted to our website at a later date. Without further ado, I would like to introduce our first speaker. Dr. Daniel Chung is professor of medicine at Harvard Medical School. He's the medical co-director of the Center for Cancer Risk Assessment and director of the High-Risk GI Cancer Clinic at Mass General. In this role, he leads a team of genetic counselors and physicians in providing genetic counseling and testing, as well as caring for high-risk individuals, including those at high risk for pancreatic cancer. This morning, Dr. Chung will be sharing the current methods for pancreatic cancer screening. Welcome, Dr. Chung.
Great, thank you so much, Kristen. Let me just pull up my slides here and then we can get started. So good morning, everyone. Thank you so much for joining us. We're thrilled to be able to offer this symposium to help you understand where we are in terms of high-risk screening for pancreas cancer. It's a pleasure to be here. So let's just jump right in. I am going to talk this morning a little bit about just the basic backgrounds about where we are with pancreas cancer in the population. What are the techniques that are available? What's the rationale behind screening and screening tests and how we evaluate them? And what's kind of new as of this year, because there are some new and interesting and exciting developments. So just by way of disclosures, I do have research funding from Immunovia. And so in terms of background, you know, pancreas cancer is becoming something that everyone knows about now. It's becoming much more common in the population, and certainly a number of diagnoses in celebrities such as Ruth Bader Ginsburg, Alex Trebek have really brought it to the forefront in the popular media. But in terms of just the overall risk, we do know that there's a lifetime risk of developing pancreas cancer, about 1.6% in the general population. And that number is actually increasing. We don't know exactly why, but we do recognize there are certain risk factors in people's lifestyles, including tobacco, being overweight, and development of diabetes that can be contributing to this. However, there probably are other factors that we don't really know about yet. And with one of the later lectures after this, we'll really talk about some of these risk factors a bit more. Now, we are focusing a little bit about people who we consider high risk. So although it's increasing the general population, we have recognized there are some risk factors that put people in a high risk category. And there are two general themes here. One is those where we see a clustering of cases within a family. And so we tend to think that those who have at least two relatives with pancreas cancer are really at the highest risks. And that can be two first-degree relatives, and that means like a sibling and a parent, or two relatives who are all in direct lineage, meaning like your mother and then your mother's mother, your grandmother, all in line having pancreas cancer, and that does increase the risk for you. We also know that there are a variety of hereditary genetic syndromes that can increase the risk of pancreas cancer. There is no known pancreas cancer gene that causes a pancreas cancer syndrome. However, we know there are a variety of syndromes that increase the risk for many other genes, many other tumors, but also pancreas cancer is included in that spectrum. And just to show you some examples, and this again will all be discussed in a great later lecture with our genetic counselor, Kathleen Steinberg, but people who have a Peutz-Jeghers syndrome, which increases the risk for a variety of certain polyps, colon cancer, as well as stomach cancer, will have a very high risk of pancreas cancer as well. People who have FAM, which is a melanoma and mole syndrome, will have a very high risk of pancreas cancer as well, a 13 to 39-fold increased risk over the average person. Individuals who have hereditary pancreatitis, a condition that predisposes to recurrent episodes of pancreatitis, will also have a very high risk. The other ones that are a bit more common are Lynch syndrome, which typically increases the risk for colon and endometrial cancer, also can have a higher risk of pancreas cancer. The BRCA breast cancer genes, as well as PALB2, will increase the risk. And ATM, which is another gene also associated highly with breast cancer, does increase the risk for pancreas cancer as well. So understanding whether one of these genes is present in the family is important to then provide an accurate risk estimate for individuals. Now, screening is something that has always been a big challenge in pancreas cancer, and there's been a conventional common views of how we think about pancreas cancer that, it typically grows so fast, there are no symptoms when you have early disease, pancreas cancer is always diagnosed when it's too late. And I think that's been a perception for decades. That has begun to change as we begin to learn more about what are the features associated with very early pancreatic cancer lesions. And the reasons that's changing is manyfold, but one of which is that we understand in terms of the biology a bit more about what are so-called precursor lesions, and meaning that cancer often doesn't just sprout up as cancer, but there is a precancerous precursor. And we know the paradigms, for example, in the colon, where people develop colon polyps before they get colon cancer, and we try to find those first. And so we now know that, for example, pannins are one such lesion, which are precancerous lesions in the pancreas. And again, the goal would be, if you can identify things when they're at this precancerous state, that you can actually probably have the biggest impact. And the other point is that we now have better imaging tests that help us look at the pancreas better and potentially enable us to identify these early precursors better. So before we jump into those specific techniques, I just want to spend 1 or 2 minutes really on just the rationale for screening, how we think about it as in the field of medicine, and what makes a good screening test. So when we think about screening, there are really 2 main questions. So one of them is really about, can you find cancer at an earlier, more treatable stage? So as you know, typically cancers are stage 1 through stage 4. Like, instead of finding something at stage 4, can you find it at stage 1 when it's likely to be more treatable and more curable? But the field also is interested in, can we not just find something when it's an early stage cancer, but could we potentially find something when it's a precancerous lesion before it even becomes cancer? And that actually becomes something more formally known as cancer prevention, right? We prevented the cancer from even forming in the first place. So there are a lot of paradigms and examples of many, many other cancers that we do screen for in the population. And many of these are cancers that are quite common, so it makes sense to kind of do that. But these are things like colonoscopy for colon cancer, mammography for breast cancer, Pap smears for cervical cancer, PSA for prostate, and CT scanning for lung cancer. Now, what makes a good screening test? And so some of this sounds pretty obvious, but I think that it's important to just make sure we understand each of these principles. So it needs to be accurate, right? So that you don't want a test that's going to give you lots of false negatives or lots of false positives. And false positives can often be quite a challenge because you start hunting down things that really were never anything to worry about at all. And so you don't want to put people who are perfectly healthy and feel fine through additional testing that may be unnecessary. You want a test that's pretty simple to do, that's going to have minimal risk, because the last thing, again, you want to do is create harm in a situation where someone is already feeling perfectly healthy. And again, in order for it to be kind of widespread, to be able to be widespread, used in a widespread way, it needs to be a low cost. And ultimately, the test and the science is that you need a large study that shows that it's truly effective, meaning that when you screen a whole bunch of people, whether they're average risk, whether they're high risk, that you can actually accurately diagnose cancer when you use this test with low rates of false negatives, low rates of false positives, and that you actually ultimately improve the outcome related to cancer, meaning that maybe you accurately find the cancer, but it's always too late and you can't change the outcomes, then it's not quite clear that that test has actually provided you any benefit. So in terms of pancreas cancer, as I said, the paradigm is shifting, and we do think that you actually can find things early when you actually can make a difference. And, I think just anecdotally, we often see in our practice many patients who have incidentally found a small pancreas cancer very early because they were, other tests were being done for other reasons. And those individuals have surgery and they're cured. And, those are great stories and really give us hope that, yes, we can actually find things early and make a huge difference. As I said, we are now learning in terms of the biology, we understand that what these early precursor lesions are and how to find them. As I said, certain pannins I showed you earlier, but there are also these things called IPMNs, and we're going to have a talk later by one of our scientists, Dr. Nabil Bardisi, to really talk a little bit more about how we kind of can use IPMNs and risk stratify IPNs as we use that as a marker for pancreatic cancer risk. Mucinous cystic plasms is a third group of precancerous lesion that we can identify and remove. So in terms of screening, it is current guidelines really focus on imaging tests that actually image the pancreas with high resolution. The three main tests that we currently offer are CT scans, MRI, MRCP, or endoscopic ultrasound. I will conclude at the end with a discussion of a couple of blood tests that have come out this year, and what the ins and outs of those tests are. So in terms of first the imaging tests, CT scans, I think many of you are aware of CT scans. It's a relatively straightforward test. It does require low doses of radiation. Often a contrast agent is intravenously injected. The test itself takes just a couple of minutes to actually get done, so it's actually quite quick and generally considered to be quite safe. This is an image of a scan here, which shows a really nice view of the pancreas like this. Okay. Now, the next one is a MRI, and MRI now is, for those of you who've not had one, it's a much bigger machine. It's a much noisier machine, and it takes much longer time to get the scan done. It is probably typically about half an hour in the scan. So people who have claustrophobia often can struggle a little bit with that. The test does not use any radiation, which is a plus, but it also does use a contrast agent. These are a couple images that show how we can identify things here in the pancreas. And this is an example of a small little lesion here seen at the tail of the pancreas. MRI is generally felt to be far superior to a CT because of its ability to identify smaller lesions within the pancreas. The third technique that we use a lot is something called endoscopic ultrasound. Endoscopic ultrasound is an endoscopy test where you're swallowing the scope, you are completely sedated, and the scope doesn't exactly look directly at the pancreas, but what happens is that there is an ultrasound probe at the tip of the scope, so that when the scope is sitting inside the stomach, the transducer can be placed right against the stomach wall, and you get a really beautiful view using ultrasound waves of the pancreas. And this is an example of an image here of the pancreas you can see lying right next to the transducer inside the stomach. And this is a great way of identifying, again, small lesions with the pancreas. And data have shown that, here we go, yeah, that if you use these techniques, that you actually can find things at earlier stages. And most of the data have suggested that endoscopic ultrasound and MRI are the two most effective modalities. And I'm just going to share you results for a couple of studies. They're a few years old, but they are the strongest ones we have right now. And so one of them was a study out in Europe, which looked at P16 gene carriers, these are the melanoma families, who ended up getting regular MRI and EUS. About 7% of them were found to have pancreas cancer. And for those that were found through this surveillance protocol, the resection rate was 75% versus historically only about 15 to 20% of people with pancreatic cancer being candidates for resection. And the 5-year survival was 24%, again, versus historically only about 4 to 7%. So that the outcomes were indeed better. I think that we hope that we want to have even better outcomes than this, but at least indicates that surveillance and screening did actually make a difference compared to historical controls. The bigger study that I think has gotten people much more excited was this one performed in, this was through centers in the United States. And this is 354 individuals followed with EUS, MRI, and CT, who had a mean follow-up of about 5 years. 19% of them developed concerning features. 7% of them progressed to more advanced lesions. And it turns out 10 had high-grade dysplasia and 14 ultimately developed pancreas cancer. That's 4% out of the entire group that's getting screened. The typical age that they were diagnosed was about 67 years, and most of them had undergone screening for about 5 years before the cancer was found. Now, the meat of the study is here, which showed that this is looking at overall survival among individuals who had pancreatic cancer, whether they were found by surveillance or whether they were found just through routine care. And the point here is that this purple bar are the individuals who had pancreas cancer found during this high-risk surveillance protocol. And there were 10 such patients, as we mentioned. 9 out of 10 were resectable, and the 3-year survival among those individuals was 85%. There were 4 patients who had pancreas cancer identified who were not undergoing routine surveillance. And among those individuals, none had a resectable tumor, and the 3-year survival was only 15%. So it indicates that if you do the surveillance, you have a much better chance of finding a tumor that's at an earlier stage and then can be treated. And so this leads us to where we are in terms of the formal guidelines that have been sort of put together by a number of national societies, including pancreas societies, cancer societies, GI societies. And the focus here is on what we call high-risk individuals. So we don't recommend screening for just anyone in the population, but we recommend screening for those who are at high risk. And how do we define high risk? High risk is anyone who has one of these genes that we talked about earlier, and we'll go into more detail with Kathleen Steinberg. But if you have hereditary pancreatitis gene, this sort of so-called Poids-Jaeger gene or melanoma gene, you should get screened. If you have a BRCA gene, the PALB2 gene, a Lynch gene, or an ATM gene, the recommendation is a little bit modified, and it's based on having the gene plus a family history of pancreatic cancer. So the risks there are lower than the other things in the first 2 categories, but if you have one of the genes, BRCA, PALB2, Lynch, or ATM, you need to have a family history as well in order to be considered eligible for screening. For those who've had no gene testing but have a strong family history, if you do, as I mentioned, for 2 or more close relatives, either 2 first degree or 2 first and second in the direct lineage, then you would also be eligible for screening. So 1 relative in general is not enough to recommend screening. And the screening protocol here is using MRI and EUS, and we will start at age 50 or 10 years younger than the earliest diagnosis in the family. And we generally go back and forth. We'll do an MRI 1 year, EUS the next year, and so forth, going back and forth. In general, it's recommended this is done at an institution that has expertise in this, and ideally in conjunction with some sort of a protocol to actually understand outcomes. Now, that's what we've been doing for the past few years. There have been a couple of new blood tests that have been introduced this year in 2021. And many of you may have heard about these, and I want to just take a moment here to kind of talk about each of these 2 in a little bit more detail. So the first one is the IMRAY test, which is developed by a company called Immunovia. And what it's, as I said, it's a blood test. And what it does is it assesses multiple blood circulating protein markers that have been associated with pancreatic cancer. And it's a proprietary mix of proteins at this point. So, and what the data so far have shown is that when they have used this marker looking at individuals who actually have pancreas cancer, that the sensitivity for those who have very early stage, and I think that's the point here, you want to identify things early. And so for stage 1 or stage 2 pancreas cancer, the sensitivity is 89%. So that means of all of those individuals who had early stage pancreas cancer, 89% had a positive marker. There were about 56 patients in that pool. The specificity is 99%, and specificity means for everyone who does not have pancreatic cancer that they tested, 99% of them tested negative. So this means that the false positive rate is actually quite low. The second test is something called the Gallery test, which is made by Grail, the company called Grail. And what this is again, a blood testing. It's not specifically for pancreas cancer, but it's assesses, it's looking for 12 different cancer types, which include pancreas cancer. And this, instead of looking at protein markers, looks at DNA, circulating DNA markers. And what they have shown, and I'm focused just on the results related to pancreas cancer, that in their particular panel and testing they have done, that for stage 1 pancreas cancers, their sensitivity was 63%, meaning that out of 63% of the people who have that early stage cancer had a positive test. The confidence interval was quite wide, between 24 and 91%, and their sample size was quite a bit smaller, only 8 patient study there. Again, the specificity, though, was quite high, again, meaning that everyone they tested for who did not have cancer, 99.3% had a negative test. So again, false positive rate was really quite low. So what do we do with these markers? And so I just wanted a few kind of additional facts and discussion points about these blood tests. So they are offered what are, the FDA is considered as laboratory developed tests, or LDTs, which means they have not been formally approved by the FDA. It's not that they've been rejected, it's just that they have not been put forth to be approved by the FDA. So they are available, commercially available for testing. They do need to be ordered through a physician. There are no data at this point on performance of these tests specifically in a screening population, meaning that taking a whole bunch of high-risk pancreas cancer patients, using the test on those and seeing what outcomes you get specifically in a screening group. I think there are some studies that are ongoing, but we do not have data on that yet. So currently the test, as I said, can be offered through a physician order. It is not covered by insurance at this point, and is generally about, each one of these I think is around $1,000. And in terms of then who should consider getting these blood tests, there are no, because these have not been vetted really by any of the kind of national societies, that there are no formal guidelines really yet as to who should actually get it. Is anyone average risk should get it? High risk individuals, how often you should get it? And I think there's still a number of unanswered questions about how to use it, how often to do it, and what kind of workup you need afterwards. So they are available, but they do require, as I said, it's not something you can order directly through the company, but you do need to have it ordered through your own physician. All right, so I will end there. I do think that, I just want to conclude by just saying that, the field is continuing to move forward, and that we are excited about kind of the number of opportunities and developments that are current as well as on the horizon for new ways to screen. I think that many of our goals focus not just on new testing strategies, but also can we actually identify better who are the people that really ought to be screened in terms of risk stratification. So thank you so much for your attention. And I think we have a few minutes for questions right now.
Thank you, Dr. Chung, for that wonderful talk. We do have a couple of questions, and I want to encourage everyone to use the Q&A button at the bottom of their screen if they do want to ask a question. The first question is, how does the blood test you just spoke about change the clinical diagnosis?
So the blood tests, so the blood tests are considered screening tests. So I think that the way that they would be used is that if you did one of those blood tests and it came back positive, your physician would presumably then want to do some kind of a workup in which you then had imaging and an MRI, a CT, ultrasound, et cetera, to see if you have some kind of a pancreatic tumor there. So that's the presumed workflow, but that's something that would be worked out with your own physician. And this is again where I say that some of the data, we don't really have enough data to know that if you have the blood test and you have an imaging test and it's negative, is that really negative? Was that just a false positive blood test, or do you need to do additional testing? Should you have the blood test again or imaging again in a few months? Those are the kinds of questions that we don't know the answers to. So it doesn't necessarily change your diagnosis. It certainly is a test that could potentially help figure out, is there something there that needs to be further evaluated?
Thank you. I have another question, and the question is, how do I find a facility with expertise for screening?
That's a great question. I think that I will say that most of the institutions that have experience are going to be probably larger academic institutions. There are a number of sites that you can find through a variety of foundations, I think through PanCan Network or Lustgarten Foundation will often have sites that have centers that have expertise in pancreatic cancer management in general. I think you might want to look for places that are NCI designated cancer centers, which will have more expertise in managing all of these aspects. But I would probably start with the largest academic center within your geographic location.
Thank you. There's also a question about the use of a PET scan and whether or not that has been helpful in detecting pancreatic cancer.
That's a good question. So PET scan is generally not used as a screening test for a variety of reasons. I think some of it is there can be a lot of false positives. It's an extremely expensive test, as you can imagine, and does have some potential side effects associated with it. So there are no data really now about using PET for screening. And so currently it is not used as a screening tool. Whether it might be used as a diagnostic modality, if there's some kind of abnormality is seen, certainly is reasonable, but as a screening test, that's not, we don't use that as routinely.
Great. Here's another question, and this question is a lipase blood test an accurate marker for diagnosing pancreatic cancer?
So lipase is a marker, is an enzyme that is produced by the pancreas, and generally it's used for a diagnosis of pancreatitis, which is inflammation in the pancreas. So lipase is generally, I would say, not a useful marker for screening or making that diagnosis.
Okay, great. And then another question, should individuals with a BRCA2 mutation and no family history of pancreatic cancer consider screening?
So that's a good question. I think that the current guidelines are that we do not recommend screening for people who are BRCA2 positive and have no family history. It does turn out that there is a small risk of pancreas cancer in BRCA2 individuals, but the vast majority of those with BRCA2 are not going to get pancreas cancer. It is believed that risk does go up if you have a family history. This is an area where I think there does need to be a little bit more research to kind of really truly understand who's at the highest risk if you have a BRCA2 mutation. I think if there is concern or if there are other potential risk factors in the family, you certainly can discuss that with your physician. But the bottom line is that if you're BRCA2 without a family history, we generally do not recommend pancreas cancer screening.
Okay, thank you. One more question is, having one parent with a pancreatic cancer does not make an individual at high risk. Is that true? And if not, should a person that has one parent with pancreatic cancer still pursue screening tests?
Oh, that's a great question. And that's one that we see often. So having one parent with pancreas cancer, certainly it does increase your risk, but a little bit. And so it's not certainly to the same extent as having two relatives. And so, we would put you in a category, there's maybe, a mildly increased risk. But given what we know about the level of that risk and the effectiveness of screening tests that we have, that most societies will not recommend screening for individuals with just one first-degree relative. Now, there can be extenuating circumstances if, for example, that one relative was particularly young in age, like under 50 or something, we would say, yes, that may be something you should consider. I think that what we do in these scenarios primarily is try to get a better risk estimate and risk calculation for you and your family. And the first step there usually is genetic testing. And so we would recommend that a genetic evaluation be taken place within the family to determine whether there is a genetic marker that can explain that risk. And if that's true, then we can actually make more precise and formal recommendations about what you should do.
Great. Well, thank you so much, Dr. Chung. In the interest of time, I think we're going to move ahead. Thank you for all of the questions, and we'll try and answer them through the chat and through the QA function. So the next speaker is Dr. Andrew Chan. And Dr. Chan is a professor of medicine at Harvard Medical School, the chief of the Clinical and Translational Epidemiology Unit, and the director of cancer epidemiology at the Mass General Cancer Center. This morning, Dr. Chan will be discussing how diet and lifestyle play a role in pancreatic cancer risk. Welcome, Dr. Chan.
Thanks, Kristen. Good morning, and I'm really happy to be here to share with you some information about lifestyle factors and pancreatic cancer risk. This is a very commonly asked question for patients and families who would really like to understand what it is that they can do about their individual lifestyles to really modify the risk of pancreatic cancer. As Dr. Chung had mentioned, we certainly know there are genetic risk factors for pancreatic cancer, but we also are increasingly understanding more about lifestyle and its impact on risk. So just to give you a sense of the epidemiology of pancreatic cancer, at this point in time in the US, pancreatic cancer is the fourth leading cause of cancer-related deaths. It's also the fourth leading cause of new cancers in the United States. As you can see here, it just trails behind lung, colorectal, and breast cancer. But what's alarming in particular about pancreatic cancer is that it's a cancer that's rising in incidence. So these are data which show trends in pancreatic cancer incidence compared to other cancers over time in the United States. As you can see here, the purple line is pancreatic cancer. And since 2010, the increase in incidence of pancreatic cancer has been alarming. It's one of the fastest increasing cancers in the United States. In addition, liver cancer has been rising in incidence, but most other cancers, such as colorectal cancer and lung cancer, have actually been declining in incidence. So it is becoming an increasing public health problem. And what makes pancreatic cancer particularly worrisome is that it's very commonly diagnosed at an advanced or metastatic stage. And as Dr. Chung had mentioned in his talk, we are trying to shift the curve with respect to diagnosis of pancreatic cancer to earlier stages through things like endoscopic ultrasound and MRI screening of high-risk patients. But despite these changes, we still know that most pancreatic cancers are diagnosed at a later stage. As you can see from this table, the vast majority of cancers are diagnosed at a locally advanced or metastatic stage, as opposed to resectable stage here. 80 to 95% of patients actually have incurable disease at the time of diagnosis. So what do we know about pancreatic cancer risk so far? And these are just this is a nice summary, I think, of predisposing factors to pancreatic cancer that we think actually are important to consider. As we've already mentioned, family history and genetics plays an important role. We've also heard about the role of chronic pancreatitis or pancreatic inflammation, which can be a risk factor for pancreatic cancer. We know there are certain demographic risk factors, such as being male or being of African American ancestry. And then we also know more about lifestyle factors. In particular, we know tobacco use is a strong risk factor for pancreatic cancer. And also we understand increasingly that obesity, type 2 diabetes, and other disorders where there's metabolic issues with respect to insulin resistance predispose people to pancreatic cancer. In addition, there are diet factors that may play a role. Heavy alcohol use may play a role in risk of pancreatic cancer, as well as physical inactivity, vitamin D insufficiency, and also I'll mention a little bit about the role of allergy. So a word about demographics. Well, most pancreatic cancers are diagnosed at an older age. The median age of diagnosis is actually 70 years. It's much more commonly diagnosed in men. It's more commonly diagnosed in Western cultures, and within the US, it's more commonly diagnosed among African Americans. And this is just a graph which shows that diagnosis of pancreatic cancer is relatively unusual at younger ages, certainly less than the age of 50 is unusual. But as you sort of go into the more advanced ages, you see about 30% of cases are diagnosed after the age of 65 to 74, 25%, 75 to 84, and 13% over the age of 84. We do know there are differences with respect to males versus females. Also more common, again, diagnoses among Black men in particular, as well as Black women. So there are clear demographic factors that are at play. What's also been quite clear is that there is differences now or trends in the age of onset of pancreatic cancer. Although the vast majority of cases are diagnosed at older ages, we are seeing an alarming increase in rates of pancreatic cancer in younger individuals, which also may be predominantly found in women versus men. So these were data that were just published recently in the Journal of the American Medical Association, which showed again, the trends are alarming with respect to increases in incidence of pancreatic cancer across all ages. But I want to draw attention to this lower graph here, which is focused on people between the ages of 15 and 34, or very young individuals. You can see here that there is an increase in incidence of pancreatic cancer in women at a considerably higher rate than men. And that's quite different than the other ages, where you see men being diagnosed more commonly than women in older ages. So why we're seeing more women being diagnosed with pancreatic cancer at younger ages remains to be seen as to why that is. So going through specific risk factors, first and foremost, we know that tobacco use is a risk factor for pancreatic cancer. This is one of the earliest prospective cohort studies that showed that pancreatic cancer is linked to smoking. You can see here that current smokers had a 2.5 higher fold relative risk increase in pancreatic cancer compared to those who never smoked. So in other words, someone who smoked had a 2.5-fold higher risk of having pancreatic cancer than someone who didn't smoke. And past smokers had a risk somewhere in between, about 1.2-fold higher risk compared to never smokers. With respect to pancreatic cancer, as I mentioned before, that's a chronic inflammatory condition of the pancreas, which has both inherited and environmental causes. This was a study called PAN-C4, which was a questionnaire-based study, a case control study done to look for risk factors of pancreatic cancer. And what was found here was that people who had a history of pancreatitis had a substantially higher risk of pancreatic cancer, about 2-fold higher risk of pancreatic cancer if they had pancreatitis more than 2 years in the past. Those people that had pancreatitis relatively soon after diagnosis had a relatively high risk, and that may be because the pancreatitis was an indicator of an early lesion of pancreatic cancer. So in general, we do think that there is a higher risk related to having pancreatitis or inflammation of the pancreas overall. In particular, there's a rare condition called familial pancreatitis, where there is a gene that may be associated with a higher risk of pancreatitis in families. where the risk of pancreatic cancer may be as high as 50-fold. What about alcohol use? This was an amalgamation of many studies that were done looking at the association of alcohol with pancreatic cancer, and across 10 different studies, they assembled over 5,000 cases of pancreatic cancer compared to nearly 12,000 controls. And as you can see from this table, if you drink relatively modest amounts of alcohol, i.e. 3 to 4 drinks per week, there is no increase in risk of pancreatic cancer. But as you start to drink more per week, i.e. 4 drinks per week, 5 drinks per week, all the way up to 8 to 9 drinks per week, you start to see about a 1.6-fold higher risk of pancreatic cancer. So about a 60% increase in risk of pancreatic cancer compared to those who don't drink at all. So the message here is that moderate to small levels of alcohol are probably not a risk factor, but as you start to get to heavy alcohol use, it is a risk factor. I'm commonly asked about diet because there's obviously a lot of interest in knowing about what we can do with respect to what we eat every day to help modify our risk. So I want to point out 2 different studies that address this question. One is the NIH American Associations of Retired Persons Diet and Health Study, which was a survey of over 500,000 people between the ages of 50 to 71 that have been followed for several decades. And in that particular cohort, about 2,000 people developed pancreatic cancer. And they then looked and tried to assess what sort of diet was linked to the development of pancreatic cancer in this cohort of older individuals. And they found that this healthy eating index, which is a diet quality score, which is associated with eating healthier foods, i.e. lower amounts of red meat, higher amounts of whole grains, fruits and vegetables, was associated with a lower incidence of pancreatic cancer. You can see here overall, there's about a relative risk or odds of getting pancreatic cancer of 0.85. So put another way, that means about a 15% lower risk of developing pancreatic cancer if you observed a healthy diet pattern. This was also verified by a recent study done in Singapore of Chinese individuals. 61,000 people were followed over 17 years. What they found was individuals that had a diet that was higher in vegetables, fruit and nuts, cereals, dairy, legumes, and low in alcohol and meat products had about a 35% reduction in risk of pancreatic cancer, as you can see here. So the relative risk of getting pancreatic cancer was 0.65 or a 35% risk reduction. So it does appear that a healthy diet may help modify someone's risk of developing the disease. What about low fat? There's a lot of interest in low fat diets, and that's been historically related to interest in this dietary pattern in relationship to cardiovascular disease. There was a study called the Women's Health Initiative Dietary Modification Study that looked specifically in the randomized trial when you put people on a low fat diet compared to a standard diet, whether that impacted risk of many different diseases, including cancer. And what they found that there was not a substantial difference in the incidence of pancreatic cancer with a low-fat diet compared to people that had a sort of regular diet. So fat in and of itself may not be an important factor. What was intriguing was that if you split the individuals up into their baseline body mass index, so someone who tends to be having a body mass index of 25 or overweight or obese, a high-fat diet, a low-fat diet, excuse me, may have actually had somewhat of a harm. So it was a very difficult study to interpret. But the bottom line is we don't currently recommend low-fat diet to patients. What we do recommend, however, is a healthy dietary pattern, like a Mediterranean type diet. How about sugar? Well, concentrated sweets is a concern for patients. We've seen in several different studies, including this study published out of the Scandinavian countries, that people who ingested high levels of sugar had about a 70% increase in risk of pancreatic cancer. In particular, people who drank concentrated sweets in the form of soft drinks, like sodas and colas, had about a 93% increase in risk. And the mechanism is probably because those high levels of sugars and simple sweets tends to trigger your body to produce insulin, and insulin is known to promote cancer cell growth. So we do try to discourage the consumption of very concentrated sweets. Marine omega-3 fatty acids is of particular interest. This is the kinds of fatty acids that are found in fish and seafood. And there was a study in Japan that looked at 140,000 volunteers. And what they found was that people who ate the highest quartile or the highest level of fish and seafood had about a 30% reduced risk of pancreatic cancer. So this has been also a source of interest in trying to promote the consumption of fish and seafood in substitution for things like red meat. How about vitamin D? There's been a lot of interest in vitamin D in particular because some studies have shown that people who are vitamin D deficient may have an increased risk of pancreatic cancer. So it stands to question whether if you take in vitamin D supplements, does that actually reduce your risk? It doesn't appear to be true. It seems that many different studies looking at vitamin D supplementation and trying to get your levels of vitamin D to sort of super therapeutic levels doesn't seem to really help. So it does appear that maybe deficiency or having very low levels of vitamin D might be a problem, but over repleting or over increasing your level of vitamin D may not significantly reduce your risk. So this was sort of all brought together by the World Cancer Research Fund, which is a group that's been enlisted by the World Health Organization to assemble evidence related to diet and risk of cancer. And they came out with an opinion statement to suggest that there was some evidence that intake of red meat, processed meat, saturated fat, and potentially high levels of coffee was a risk for pancreatic cancer. So this was something that has been promoted to some extent by the World Cancer Research Organization. But I would say this remains to be studied in more detail. There are actually some very intriguing and interesting studies suggesting the opposite with respect to coffee, and that coffee may be associated with a lower risk of pancreatic cancer. How about obesity? So this was a study that was done in the Journal of the American Medical Association back in 2001, which really established that obesity was a risk factor. As you can see here, those people that were considered obese or body mass index over 30 had about an 80% increase in risk of pancreatic cancer, both in men and women. Even being relatively overweight also was associated with about a 30% increase in risk of pancreatic cancer. Physical activity in and of itself, independent of obesity, may be associated with pancreatic cancer risk. In particular, those people that are the most active have a lower risk. Case control studies have shown that there's about a 30% reduction in risk of pancreatic cancer in those that are the most active. Cohort studies have shown about a 15% reduction in risk of pancreatic cancer to those that are most active. How about diabetes? Well, this was a very early observation found back even in the 1930s that people who had pancreatic cancer tended to have a higher prevalence of being diagnosed recently with diabetes. So this was something that actually created a lot of concern as to whether we needed to do more with respect to screening patients with diabetes. But it's really been shown that that increase in risk that was first observed in the 1930s was probably overstated. It may have been that people with early pancreatic cancer developed relative problems with their pancreas that made them diabetic. So it wasn't the diabetes per se that caused their pancreatic cancer. It was more that people with pancreatic cancer had early signs of diabetes. And so more recently, there have been studies that have shown that probably diabetes increases your risk of pancreatic cancer, but probably by only about 50% if it was something that you had about that, if you were diagnosed with diabetes over 10 years in the past. And then finally, I wanted to mention something about allergy, which is a very intriguing new area of research. We do know that people who tend to have seasonal allergies, like hay fever or animal allergy, actually have a lower incidence of pancreatic cancer. And although this probably doesn't have any practical public health implications, you obviously can't control whether you are prone to hay fever or allergy to animals, it does create some interest in understanding what is the overlap in the risk factors for allergy and pancreatic cancer. Is there something about being prone to allergy that may mechanistically protect you against developing pancreatic cancer, which could lead in the future to a better understanding of why people develop the disease and also some potential implications for treatments in the future. And then a note about medications. There are data that certain medications may reduce risk of pancreatic cancer. There's been interest in metformin, which is a drug that's used often in the treatment of diabetes or pre-diabetes, but the data are quite conflicting as to whether there's any change or difference in pancreatic cancer risk with the intake of metformin. There's been some question about insulin being a risk factor. It may be in some studies a risk factor, but that probably is more a marker of diabetes being associated with pancreatic cancer overall. There's been an interest in statin drugs. These are cholesterol-lowering agents that a lot of people take for reduction of cholesterol, and there's been an interest in potentially these drugs having an anti-cancer effect. But these are not studies that have been very consistent, and so at this point, we don't recommend statins for the prevention of pancreatic cancer. And then aspirin has been an area of interest. There's been very compelling data that aspirin reduces the risk of colorectal cancer and colorectal polyps, and that's found in many different randomized trials. But the data for pancreatic cancer are not quite consistent. This was a very interesting study that was done, which linked clinical trial data of aspirin to various cancer outcomes. And what they did find was that people who took aspirin were less likely over time to develop pancreatic cancer. So the people who took aspirin are here in red, and the people who didn't take aspirin were there in blue. And you can see over time, the people in red who took aspirin had a lower rate of developing death from pancreatic cancer. So this has raised some interest in potentially the use of aspirin for pancreatic cancer prevention. But at this point, there is still not enough data to make it a formal recommendation, although some patients certainly are thinking about this in the context of taking aspirin for other chronic disease prevention, like heart disease. So in summary, I will provide you this table, which gives you just a nice summary of lifestyle risk factors of pancreatic cancer that you can think about and reflect upon with respect to your own individual situations. In terms of the group of risk factors at increased risk, we know that smoking, chronic pancreatitis, heavy alcohol use, red meat, likely sweetened beverages, diabetes, and potentially insulin may increase your risk of pancreatic cancer. And in terms of lower risk, we know that a low-fat diet, fruit and vegetable intake is probably good to do in terms of a lower risk. And physical activity is a good way to lower your risk. There is a question about people who tend to have allergic conditions having a low risk of pancreatic cancer. And finally, there's an open question with respect to aspirin use and lowering risk of pancreatic cancer, which requires more study, but certainly is worth considering if you are thinking about taking aspirin for other health indications. So with that, I will finish with my formal comments and would love to take questions from the group.
Thank you so much, Dr. Chan. That was a great talk. So just a reminder to everyone to use the Q&A feature to ask some questions. And Dr. Chan, the first question that I have is, what are the current correlations between late onset diabetes and pancreatic cancer?
So I think we're still at a point in time where we think that there might be some small association between diabetes and development of pancreatic cancer, and that could be in part related to also an association between overweight and higher body mass index with both risk of pancreatic cancer and diabetes. So some of the pathways that are occur when someone is overweight, or some of the metabolic factors that result when someone has diabetes, could also put somebody at risk for pancreatic cancer. Well, we think that increase in risk is probably relatively modest. It's probably on the order of 50 to 60% increased risk, certainly not the very, very high levels of risk that had been proposed very early on when some of the earlier studies were released, which were probably, again, due to the fact that people with early stage pancreatic cancer were developing diabetes as a result of the pancreatic cancer, and so the diabetes sort of being a risk factor for the development of pancreatic cancer. So I think we're still at a point now where we do think it's a risk factor, but probably not an overwhelming risk factor.
Terrific, thank you for that. The next question is from a participant that wants to know, is there any evidence that eating organic food lowers the risk of pancreatic cancer?
There is not. I think it's always been a question that people have also had on their minds with respect to is eating organic something that people should be doing to modify cancer risk in general, not even just pancreatic cancer. And I think that comes from concerns about the way we produce food and whether there is potentially contamination of foods from things like pesticides, et cetera. But there have not been compelling data to support a direct link between food production and regular sort of standard agricultural practices and cancer in general, and also pancreatic cancer specifically. So we, at this point, don't have enough information to recommend that organic food is a better way to go with respect to lifestyle modification.
Great. So the next question is from a participant that wants to know, are the lifestyle modification factors that you just talked about for risk reduction, are they also observed in those with a hereditary predisposition to pancreatic cancer?
That's a great question. So most of the studies that have been done related to lifestyle and pancreatic cancer risk have been done in the general population. So not in populations where there is potentially hereditary factors at play as well. So we don't have enough information to really know how much these environmental or lifestyle factors play into hereditary risk. So it certainly doesn't obviate or create a situation where if you observe these lifestyle factors, you don't need to get potential for example, pancreatic cancer screening, or recommend that your family members get tested genetically. But there is probably no downside to observing some of these lifestyle factors if you do have hereditary risk. Certainly, a healthy diet, staying more physically active, and trying to maintain a healthy body weight would likely be a benefit to someone even with a hereditary risk. So I think we do feel like there's a safe ground to kind of extrapolate data from these studies, but there haven't been studies that have been focused specifically on those with hereditary risk factors.
Interesting, definitely a need. Another question is regarding physical activity. And is there a difference between the risk lowering effect of physical activity that is more cardio as compared to strength training?
Very good question. So we do have, again, very little data with respect to type of physical activity and cancer risk. We do think that relatively moderate levels of activity, even walking, tends to be associated with lower risk. It doesn't have to be necessarily very vigorous activity, but there aren't a lot of studies to compare cardiovascular training versus strength training. That is something that people are looking more deeply into. It's been of interest for other health outcomes like heart disease, and it's now something that people are really studying more vigorously within studies of cancer risk.
Interesting. And this next question is regarding risk definition. So the question is, when you say that people who ingested high levels of processed sugar had a 70% increase in the risk of pancreatic cancer, what does that mean? Does it mean that their lifetime risk of developing pancreatic cancer is 70%?
No, so that's a great question and good thing to clarify. So a lot of these studies are done to compare people, for example, who eat the highest level of sugar compared to the lowest level, and they compare the relative increase in risk. So if you compare those two people, the person who eats high amounts of sugar has a 70% relative higher risk of pancreatic cancer compared to someone who eats low amounts of sugar. But that's a relative difference. It's not an absolute difference, meaning the absolute rate of pancreatic cancer is still low, and it's still low in the general population. So if we think that the risk of developing pancreatic cancer in the general population is somewhere on the order of 1% to 2%, then that incremental 70% relative risk means you go from a 1% to 2% lifetime risk to a 1.10% absolute risk. So it is very tricky to kind of wrap your head around, but it doesn't suggest anything to mean that you individually have a 70% risk of getting it over your lifetime. It's definitely, doesn't mean that. It just means how you compare to someone who eats less sugar.
Got it. Thank you so much, Dr. Chan. Just a reminder to continue to use the Q&A function, and then at the end of the conference, we will have some additional time to answer more questions. But we're going to move on to our next speaker, who is Nabil Bardisi. So Dr. Nabil Bardisi is an associate professor of medicine at Harvard Medical School. His research laboratory focuses on defining the pathways driving the pathogenesis of pancreatic and biliary cancers. Today, Dr. Bardisi will discuss IPMNs and pancreatic cancer risk. Welcome, Dr. Bardisi.
My name is Nabil Bardisi. I'm a PhD scientist focusing on pancreatic and biliary tract cancers. It is a pleasure to be speaking to you today. I'm going to provide a broad overview of research topics relating to the biology of pancreatic cancer. I also speak about one of the main precancerous states that can develop into pancreatic cancer called intraductal papillary mucinous neoplasms, or IPMN. I've summarized my talk here, beginning with the diverse gene mutations that occur in subsets of patients with pancreatic cancer, then covering the biology of the precancers. I will then touch on what we've learned about the different gene mutations, in particular regarding more specific therapies. I'll also introduce two important emerging topics: how these tumors fuel their growth by taking up nutrients, and how they avoid being killed by the immune system. I will not be covering chemotherapy approaches that have made great advances in recent years, but rather emerging approaches to target the cancer based on its gene mutations. For general background, I've depicted the anatomy and histology of the pancreas. The pancreas has two main functions. The acinar cells generate digestive enzymes that are transported to the pancreatic ducts, shown here, into the intestine. The pancreatic islets, shown here, produce hormones like insulin that regulate metabolism of our whole body. There are also connective tissue cells, called fibroblasts, and some immune cells. The most common and difficult to treat type of pancreatic cancer, ductal adenocarcinoma, abbreviated PDA, resembles the pancreatic ducts, as its name suggests, but contains a mixture of many other cell types, such as blood vessels, immune cells, and connective tissue cells, shown in the schematic here. And all of these cell types influence the way that the tumor grows. Pancreatic ductal adenocarcinomas arise due to a series of different gene mutations, which in most cases arose during adulthood rather than being inherited. A striking hallmark of pancreatic cancer is that virtually all patients have mutations in the KRAS gene, which I'll discuss in more detail later. In addition, there are diverse mutations present in subsets of patients. And we're just now figuring out the influence of these genes on the growth of the cancer and treatment response. These questions will have to be addressed so that we can develop more personalized and effective. Before I cover ongoing laboratory research, it's important to mention a significant area where there's already been progress in this regard. That is, in patients with germline mutations that affect the ability of the cells to repair their DNA. A recent study from the Dana-Farber, for example, indicated that 10% of all patients with pancreatic cancer arise in this context. And among those with a family history of pancreatic cancer, 20% have mutations in these genes that I've listed here involved in DNA repair. BRCA1 and 2, ATM, and so on are well-known examples, as well as MSH2 and 6. A key reason why germline testing matters is that the presence of some of these mutations allows for more targeted therapy. For example, BRCA mutations, which again, BRCA genes are involved in DNA repair, they confer sensitivity to drugs called PARP inhibitors. And this image shows that a survival is increased, the blue line, in patients with these mutations who are treated with PARP inhibitors. And so a clear slowing of the tumor in patients with these mutations. There have also been multiple clinical trials that have established the efficacy of immune-stimulating drugs called checkpoint inhibitors in solid tumors with mutations in another type of DNA repair gene, which result in the phenomenon of microsatellite instability. And these are the MSH genes that I referred to earlier. And these mutations make the cancers more recognizable to the immune system. And this chart here shows the degree to which tumors shrank upon treatment with anti-PD-1 immunotherapy. So these are sort of very important examples that subsets of patients with specific mutations respond to targeted therapy among pancreatic cancers. To further emphasize that pancreatic cancer is not a uniform disease, I've illustrated some details about the two main precancers that can give rise to pancreatic cancer. On the left, pannin, or pancreatic intraepithelial neoplasia. This is the more common precancerous state, and these precancers are microscopic. They can't be detected with any standard imaging methods. On the right, we have cystic tumors, which include IPMNs and another type of tumor called MCNs. These can indeed be detected by scans, and patients with any type of pancreatic, individuals with any type of pancreatic cysts are very common in the general population. So with this frequency, we need to better understand their potential to give rise to pancreatic ductal adenocarcinoma. We do have a good idea of what gene mutations cause normal cells to become pannin or IPMN, and also those that occur later that drive these early cancers into full-fledged cancers. And what's notable in this image is that KRAS mutations are shared by most pancreatic cancers, regardless of the root, whereas IPMN, the cystic IPMN, are really defined by the concurrent presence of these RNF43 and GAS mutations. The focus of many of the fields, including our lab, has been to study KRAS and how the various mutations that occur with KRAS influence tumor biology. And one area that I'll just highlight here is some of these IPMN mutations. One method to study these mutations is to develop mice that are genetically engineered to have these similar mutations found in different subsets of patients with pancreatic cancer. And I've just summarized some of this work here that, in fact, you can quite closely mimic the biology of human pancreatic cancers in the mouse by using these different combinations of gene mutations. And so the field and our laboratory and others have models of IPMN, of pannin, and of advanced cancers that emerge from these. So now we can go back to this pie chart and sort of think about whether we can decipher more features of the biology of the different mutational subsets of pancreatic cancer, with the hope ultimately of seeing progress to developing. Now I'll turn to the KRAS gene mutations, which are present again in more than 90% of patients with pancreatic cancer. KRAS has normal functions in cells throughout the body. When cells have a growth signal, such as during the development of the embryo or in the repair of damaged tissues, KRAS is activated by this growth signal and coordinates many processes at once, which I've listed here. But this is tightly controlled. KRAS is quickly turned off when the growth signal is lost, for example, when the tissue is repaired. In pancreatic cancers, a mutation in the DNA for the KRAS gene, which changes in this 4-letter code to give rise to proteins, lead to a form of RAS that is abnormal and does not rely on a specific growth signal, and therefore is always turned on, leading to unregulated growth and unregulated activation of all of these cellular processes. A lot of work has been done in studying the role of what KRAS does when in fully formed pancreatic cancers. In the study that I'm going to show here, using a mouse model, a genetic trick was used to suddenly turn off RAS in fully formed tumors in the mouse. Here's an MRI image showing with the mice when RAS was on, and you can see this tumor in the pancreas. Using this genetic trick and imaging again with MRI 7 days later, you can appreciate the dramatic shrinkage already within just 7 days of turning off mutant RAS. On the right is histology images of different mice where KRAS is on or turned off from different numbers of days. What you can see is very rapidly the tumor cells, which are these dark blue regions, are rapidly replaced by connective tissue cells and immune cells. And this remains for more than 70 days, where you can now start to see normal pancreas and very little active tumor tissue. So these and other studies have suggested that KRAS medicines, or medicines against KRAS, might be effective against pancreatic cancer. The challenge for many years has been that pharmaceutical companies were unable to make anti-KRAS drugs and had all but given up. However, researchers at universities and medical schools continue to pursue this problem. In the last few years, there's been remarkable success in developing the first KRAS inhibiting medicines. And they're showing promise in patients with several types of cancer, One is illustrated, one of these KRAS medicines illustrated here. However, there's an additional challenge that there are many slightly different forms of mutant KRAS in cancers, resulting from the precise change in the KRAS DNA. And I'm showing on the right here, across all cancers, different individual variants. So for example, this G12D is just one version of this altered KRAS that's the most common in pancreatic cancer. Whereas another version, KRAS G12C, is less common overall and much less common in pancreatic cancer. So in pancreatic cancers, it's less than 5%. This is all different cancers. So the most advanced inhibitor is the KRAS G12C inhibitor. The yellow is this abnormal change to a C amino acid to which the drug binds. So right now in the clinic, there's quite advanced G12C inhibitors that are showing a great deal of promise, but there's going to be a need to give personalized medicines to more patients to develop inhibitors that are selective against each form of mutant KRAS. And so again, these and other KRAS inhibitors are entering clinical trials for pancreatic cancer. We've also been studying other gene mutations present in subsets of patients. We've sought to determine, for example, whether the IPMN specific mutation in GNAS might also be a good target. And again, in one type of approach, we've used mouse models where we can genetically turn off mutant KRAS in fully formed tumors. We see that when we turn off KRAS in these fully formed tumors, we can see tumor shrinkage, and we can also see in histology images the loss of dividing cells. So shown below, these brown these brown staining highlights dividing tumor cells embedded in non-dividing connective tissue. But this is the key cancer genes are dividing rapidly. When we turn off GNAS, you basically lose all of this division. The tumors shrink, and the tumors also completely stop dividing. And if one now looks at the survival of the mice, instead of needing to end the experiment soon after tumor detection because of continuing growth in the tumor size, where all the mice we have to stop the experiment, when GNS is turned on, the mice live for many, many months. Again, pointing to the potential value in developing KRAS. We've also sought to fully understand how GNAS causes cancers to keep growing. And this is kind of a complicated diagram here, but it shows that we've deciphered a kind of biochemical cascade where GNS talks to other proteins, each of which could be additional types of drug targets. And here I just show an example in tissue culture. When RAS is turned on, the tumor cells grow rapidly, these fluorescent images. When GNS is turned off, growth is completely inhibited. But by studying the basic biochemical mechanisms, we've also been able to find genes that are regulated by GNAS that could similarly be turned off and also similarly block tumor growth. Again, suggesting that we might have multiple opportunities to turn off GNAS with drugs, or the things that GNAS does to other genes or proteins to keep tumors growing. These findings again provide a rationale for targeting GNS and its targets, but also surprisingly has given us insights into other cancers that converge on similar mechanisms. We found that lung cancers, bile duct cancers, and subsets of colon cancer, as well as a rare pediatric cancer, seem to be using the same mechanism. That perhaps what we're finding here will be also relevant to treatment of those cancer types. Another area that there's been a lot of advances is in the way pancreatic cancers acquire and use nutrients for energy and as building blocks for growth. First, it's worth noting that pancreatic cancers are embedded in this dense matrix of connective tissue cells. And one of the consequences of this is that the tumors are actually much less nourished than a lot of cells in the body. They're hypoxic, which means that they're deprived of oxygen, and they're deprived of abundant nutrients that they might require. So they've acquired means to more effectively acquire nutrients in this setting. And again, the field is working hard on defining what these nutrients are and how to use this information to better treat these tumors. So as a general concept, cancers require and utilize a lot of nutrients. And this creates further stresses that need to be navigated by the tumor to survive. And so growth, this rapid growth, needs to be matched by the tumor with respect to its nutrient supply. And one of the mechanisms that control this balance is actually the KRAS mutation. Is one mechanism. It effectively coordinates growth and nutrient supply. And so if we destabilize the nutrient supply relative to growth, we can have a collapse of metabolic what we call homeostasis, so the normal balance of nutrients. And that's can be achieved, in fact, in part by targeting KRAS, but also by targeting some of the other ways that these tumors acquire KRAS. This is showing that indeed KRAS itself plays a role in coordinating a very important nutrient called glucose. So it's a basic food, basic energy supply and building block for many cells in the body. This is a type of imaging method that shows that in a rapidly growing pancreatic cancer, they're actively taking out glucose, imaged in yellow here. But in that model system where we turn off KRAS and the tumors have, again, rapidly stop growing, KRAS is actively causing them to also take out glucose, and that's completely lost. Another way to potentially starve tumors is to interfere with the way they break down and recycle nutrient building blocks. So we know that pancreatic cancers have one very active process of scavenging nutrients from surrounding the cell and then rapidly breaking them down in part of the cell called the lysosome. And there are various drugs that can block the lysosomal function. Our data indicates that the ability to take up proteins and recycle them is much significantly enhanced in pancreatic cancers that have a mutation in this RNF gene, which I pointed out earlier as being a common alteration in pancreatic cancers that arise from IPMNs. And this red stain is showing a fluorescent protein that's taken up by the tumor cells, showing that there's some taken up by pancreatic cancers that don't have RNF43, but this is much more active in RNF43 mutant tumors. The process is called macropinocytosis. And so right now we're exploring the possibility that drugs that target the lysosome might be particularly effective in model systems and then perhaps in patients that have RNF43 mutations. Finally, a great deal of work has been done on trying to make immunotherapy effective for a greater proportion of patients with pancreatic cancers. A key difficulty is that for most patients, these tumors actively recruit the wrong types of immune cells. That is, they create inflammation that can actually, immune cells that can encourage tumor growth while keeping out immune cells whose job it is to attack the tumors. In this regard, an exception might be IPMNs. Our data in mouse models and supporting data in human specimens indicate that the good immune cells are actually relatively abundant in IPMN compared to Panin lesions in pancreatic cancers that emerge from Panin lesions. So here I show data on a type of anti-immune cells called cytotoxic T cells or CD8 positive T cells. On the right is a stain showing a KRAS mutant Panin with very few of these good immune cells that can be mobilized to attack the tumor. Whereas in IPMN with GNAS mutations, we can see that in regions they're actually quite abundant. And here's a quantification of that data, again showing 3 to 5-fold more of these tumor cells. That again, we might be able to use various further immune stimulating drugs to have these not just to be there in these tumors, but potentially attack it and cause it to shrink. So with this short talk, in summary, while we've made considerable strides in chemotherapy, which are very important in current therapy, we're also now entering an era of precision medicine for pancreatic cancers, where patients can be matched with treatments based on features such as their mutations in their tumors. Targeting forms of KRAS is one area of great promise. We have some subsets of KRAS mutations that can be targeted now in the clinic and will be very soon. Regarding other mutations, there's also success in precision approaches against for example, BRCA mutant cancers or MSH mutant cancers with either PARP inhibitors or immune checkpoint inhibitors. And finally, lab efforts are seeking to create the foundation for future treatment approaches against other mutations. In this brief talk, I've outlined a few ideas regarding GNAS and RNF43 mutations, and the field collectively is working hard to expand the reach of personalized therapies. So with that, I'd like to thank you for the pleasure of speaking with you today.
Well, thank you so much for taking the time.
Yeah.
Have a great day.
Kristen,
Yes.
this is Dan. There are a couple of questions in there that I could probably take.
Oh, terrific.
I'm just looking in the Q&A. So the question was about whether PANNs or pancreatic intraepithelial neoplasia can be detected through endoscopy. And I think Dr. Bardisi was indicating that certainly IPMNs we can identify, PANNs not so much. So that's a more challenging thing because those are much smaller microscopic lesions. I think that we may be able to identify things sort of as that if they become large enough as ductular changes, but in general, it's tough. Early ones are tough. And can you be tested for the KRAS gene? The answer is yes. So, but just to understand, this is not like a blood genetic test for KRAS. Oh, Nabil's still here. But you can test the tumor for KRAS mutations. And that is something that we can do and routinely do within tumor specimens themselves. So the answer there is yes. Nabil, do you have a moment here or?
So the mutation, so KRAS can have many mutant variants, and the drugs need to be made to each specific form of mutant RAS. So there's a mutation called G12C that's common in colorectal cancer and fairly common in a number of other kinds of cancer and very rare. So there's 95% of patients with pancreatic cancer have KRAS mutations, but only a few percent have G12C. So the current inhibitor is G12C. So there are trials, again, I don't know about the opening status and availability of slots, but G12C, patients with pancreatic cancer who have G12C are eligible for clinical trials with a G12C inhibitor, whereas most patients with pancreatic cancer have a mutation called G12D, and those inhibitors are coming. They've been developed and they are entering clinical trials, and that could be an enormous advance for pancreatic cancer treatment. In lung cancer, there are medicines that are sort of similar for subsets of lung cancer, and these tumors often shrink and so on. So pancreatic cancer and lung cancer have equally difficult clinical courses, but lung cancer for several years now has had subsets that are eligible for these very specific targeted medicines, like we're talking about for KRAS. And so that has really been a big change in the way those patients are treated, other than just chemotherapy. And so KRAS G12D and G12C are one is in the clinic and the other one is coming soon. So, yeah.
Great, thank you so much. I think we're out of time right now and we'd like to move on. Right now is a time for a quick break. Thank you, Dr. Bardisi, again for coming. And to all the attendees, we are going to break and we will reconvene here at promptly 10:45 for our next speaker. Thank you very much.
All right. Good morning and welcome back from break. My name is Linda Rogers and I'm one of the other genetic counselors in the Cancer Center. I will be moderating the late afternoon or late morning session for you. Just a reminder to place any of your questions in the Q&A and we'll get to as many as possible. First up, our next speaker is my wonderful colleague, Kathleen Steinberg. Kathleen is a senior genetic counselor at the Mass General Cancer Center. Her clinical and research interests include hereditary gastrointestinal cancers and hereditary hematologic malignancies. Today, she will be sharing information about hereditary risk for pancreatic cancer. Welcome, Kathleen.
Thank you for the introduction, Linda. Let me just get my slide shared. All right. So just as Linda had said, my name is Kathleen Steinberg. I'm one of the genetic counselors in the Center for Cancer Risk Assessment here at Mass General. And today I'll be presenting on a genetic predisposition for pancreatic cancer. Specifically, I'll be focusing on communicating risk in families. I have no conflicts of interest to disclose. As an agenda for today, we'll begin with a brief review of pancreatic cancer genetics, and then we'll move into a conversation about implications of genetic testing results for family members. The bulk of our conversation today, though, will be spent on reviewing strategies and challenges of sharing test results with family members. The goal of genetic testing for families with pancreatic cancer really is to answer the question, is there a hereditary cause for cancer in the family? If we know the answer to this question, this can help us in many ways. First and foremost, knowing the answer to this question may help us know if the individual undergoing genetic testing and potentially their family members are at risk for other cancers, not just pancreatic cancer. Also, knowing the answer to the question, is there a hereditary cause for cancer in the family, in some cases may help reveal the potential for targeted treatment. And then lastly, knowing the answer to the question, is there a hereditary cause for cancer in the family, as will be a focus for my talk today, may help us identify other possibly at-risk family members who potentially could benefit from additional specialized cancer screening. So who qualifies for genetic testing? Certainly anyone with a personal history of pancreatic cancer would qualify. And although somewhat less informative, anyone with a first-degree relative with pancreatic cancer, assuming that their first-degree relative, the person affected, is not available for genetic testing. And by first-degree relatives, what I'm referring to here is someone's biological siblings, parent, and children. We always know that the ideal candidate for genetic testing is an individual that actually has a genetically suspicious cancer, but that individual is not always available for testing. And so in those cases, we may instead offer genetic testing to their close relatives. So the term genetic testing typically refers to a blood or a saliva test, though in some cases, alternative types of samples are recommended or required. And this is a test that's looking for hereditary cancer markers, or more specifically what it's doing is it's assessing for changes in people's DNA, which we call DNA mutations or DNA variants. And the test is doing this by analyzing people's DNA sequences to determine whether a person inherited mutations in genes that could cause an increased risk for cancer. When it comes to pancreatic cancer, about 10% of cases are hereditary, which means that most people that have pancreatic cancer don't have it because of anything hereditary, but they have it because of other sporadic causes, or you could think of it as random causes. This also implies that most people with pancreatic cancer will actually have negative or normal genetic test results. And so, as was alluded to in an earlier talk today, the general population risk for pancreatic cancer is 1 to 2%. So what this means is, genetics aside, on the average person has about a 1 to 2% chance in their lifetime to develop pancreatic cancer. And what I've included here is a list of genes that we know to be associated with an increased lifetime risk for pancreatic cancer, meaning a risk that is above and beyond that general population risk of 1 to 2%. And the risk is outlined in the right-hand column here. Furthermore, not only do people that have certain types of mutations or changes in these genes have an increased lifetime risk for pancreatic cancer above the general population risk, but we also know that these people have an increased risk for other types of cancers depending on the gene that they have a mutation in, and that's outlined in the second column here. So overall, because of this, we would say that cancer screening and medical management recommendations really may differ significantly based on the gene that you have a mutation in. So you could say that although some people who have mutations in certain genes may be at an increased risk for certain types of cancers, individuals with mutations in other genes may be at an increased risk for very different types of cancers. Similarly, you could say that individuals who have mutations in certain genes may be recommended to undergo certain types of specialized cancer screening. Cancer recommendations for people, or screening recommendations for people that have mutations in other genes, may be very different. And furthermore, the age at which we may recommend that somebody begin specialized cancer screening if they have a mutation in one of these genes may differ significantly based on the gene that they have a mutation in. Many of these pancreatic cancer genes, like many cancer genes in general, are associated with an adult onset risk for cancer, really meaning that that risk to develop cancer just isn't significantly increased in childhood. And so because of that, depending on the gene, we may recommend beginning cancer screening when somebody is in their 20s, 30s, or beyond if they have a mutation in one of these genes. Though there are rarer circumstances that exist where people may have mutations in genes associated with more of a childhood onset risk for cancer. And in those cases, we may recommend beginning specialized cancer screening much earlier. And lastly, another reason I wanted to include this table is just to point out that when patients come to meet with us for genetic counseling and genetic testing, we may discuss something called panel testing. And panel testing essentially means testing for multiple cancer genes at the same time, such as all of the genes listed on this slide, not just testing for one or two genes. So when individuals undergo genetic testing, there are three different types of test results that they can get: positive, negative, and a result called a VUS, or a variant of uncertain significance. A positive result implies that a person has a change or mutation in one of the genes that was examined, and we know that that change is associated with an increased risk for cancer. A negative result would imply that no changes were detected in any of the genes examined, and a variant of uncertain significance is what it sounds like. It's an uncertain result. So technically what it means is that a change was detected in one of the genes examined, but it isn't known at this time if that change has the potential to cause cancer. More data is needed. And so because of that, for individuals who get variants of uncertain significance, medically, we typically treat them like a negative result for the time being. So what will my results mean for my family members? For people who complete genetic testing and their result comes back negative or uncertain, in most cases, this implies that their children will not need genetic testing. However, depending upon their family history, other relatives may benefit from testing. And your genetic counselor or the doctor that helped you order your genetic testing can certainly help you identify in this scenario if there is anyone else in the family that might still benefit from genetic testing. Alternatively, if test results are positive, meaning a change that is known to be associated with an increased risk for cancer was identified, this would imply that that person's first-degree relatives, so again, their biological parents, siblings, and children, would all be at a 50% chance to have the same gene mutation and a 50% chance not to have the gene mutation. For relatives who do have the gene mutation, specific cancer screening and/or prevention strategies may be recommended for them. For individuals who do not have the gene mutation, we would say those people are likely at more of an average risk for cancer, and thus no special cancer screening may be recommended. So why share test results with family members? First and foremost, sharing test results with family members can help your family make decisions about whether they wish to have genetic testing. It can help them understand their risk. Second, sharing test results with family members can also help your relatives' healthcare providers decide if genetic testing is appropriate, and can also help your relatives' healthcare providers decide which genetic test to order. There are many different types of genetic tests available. And then, as we had alluded to on the prior slide, sharing test results with family members in some cases can actually help your relatives take steps to lower their risk for cancer, detect it at a more treatable stage, or in some cases even prevent cancer from happening. And then alternatively, sharing test results with family members for some relatives can help them know that their risk for cancer is actually not as elevated as was previously thought or was possibly, and thus as extra cancer screening may not be necessary. When folks are ready to communicate their test results with family members, there are several steps that they can take to help the communication process move more smoothly. First and foremost, it can be helpful for people to identify which relatives need to be contacted first. So who should I share my test results with first? And in genetic counseling, we think of something called cascade testing. And so as an example, if we imagine that a person completes genetic testing and gets a positive result in cascade testing, this would mean that the first people we would offer testing to would be that individual's first degree relatives. So again, biological parents, siblings, and children. And that's because those individuals are the ones that are actually at the highest chance or highest risk to carry that same gene mutation. And after their first degree relatives have completed genetic testing, if any of them tested positive, in turn, we would then offer genetic testing to those individuals' first degree relatives. And so with this approach, you're testing more and more family members while also focusing on people that are at the highest risk to have inherited the cancer predisposing gene mutation. Overall, though, your genetic counselor or healthcare team can certainly help you identify which relatives need to be contacted first with test results. Next, in preparing to communicate with relatives, it can also be helpful to assemble a list of important medical records. First and foremost, obtaining a copy of your genetic testing report can be very helpful. As we had said before, giving your family members a copy of your test report can help them and their doctors know what genetic test to order for them, and can also help in some cases, can help your family members' genetic testing actually be a little bit more accurate. And then another document that might be helpful to get a copy of is a document that implications of genetic testing results, such as their document that may review how has your cancer screening been altered based on your genetic testing results, or how have your medical management recommendations been impacted? And then lastly, it can also be helpful to get a copy of your family tree, or in genetics, what we call a pedigree. And on the right-hand side of the slide, I've listed an example of what one of these looks like. So this is typically a document that reviews who in the family has had cancer and at what ages, and may include other health information as well. And then lastly, when preparing to communicate your test results with relatives, it can also be helpful to include a list of genetics experts and support resources. And so on this list, you may want to include the name of your genetic counselor or the name of your doctor that ordered your genetic testing. You also may want to include other professionals, anyone who maybe helped you process the results of your genetic testing. And as well as you might want to include helpful educational resources like handouts that were provided to you, or valid websites that helped you understand your genetic testing results. In terms of how to share these results, I think you know your family best, so your judgment is very important here. It can be good to think of how have conversations with your family members gone well in the past? Is there a certain location or a certain time of day with your relatives that's led to the best conversations? And with this, some people choose to share these results face-to-face, so in person, or as we are also much accustomed to these days, virtually, such as through Zoom or FaceTime. Some people choose to share these results through a telephone call or by sending a letter or an email. And one resource that I wanted to mention is a tool called KinTalk This is essentially a secure online platform that was designed specifically for sharing cancer genetic test results. It's a tool that was developed by the University of California, San Francisco. And how it works is it gives you the option to privately and securely upload your genetic testing information, and you can delegate or designate certain relatives of yours to receive a copy of your results. And then in turn, your relatives would receive technically an email, so a private secure email to access your confidential files. So for anyone who's concerned about privacy and may not want to email their relatives a copy of their genetic testing report, or may not want to physically give their relatives a copy of their genetic testing report, this can be a helpful tool. I think it goes without saying that sharing test results with family members can be very challenging for many reasons. In some families, people have different personal beliefs about medicine, healthcare, or privacy. Some people avoid sharing genetic testing results because they perceive it as bad news. Some families are distant or estranged, which can certainly make communication difficult. And then emotionally, this can be very challenging news and information to share. Although in some circumstances, when you share this type of news, relatives may react with a sense of gratitude, and they may be very thankful that you shared this information. That doesn't happen all the time. In some cases, family members may react with a sense of confusion or disbelief, or they may even deny that there is a gene mutation in the family, or they may deny the absence of the gene mutation. Sometimes common reactions can include fear or sadness, or the individual that you're speaking with may even resent you for giving this information. And another common reaction that we can see is guilt. So a sense that, someone may have willingly or unwillingly passed a gene mutation on to other members of the family, such as children, that might be putting them at a higher risk for cancer. And although this is understandable, I think it's important to keep in mind that we cannot control what genes we've already passed on to our children, just as much as we cannot control what genes we've already inherited from our parents. It can be helpful with this to keep in mind that you are sharing potentially life-saving information, even though in some cases this can be a difficult conversation. And all of these emotions and reactions are common. I also wanted to include that you certainly do not have to be an expert to share this information. You don't need to know all the facts. After you share this information, you may suggest that family members turn to professionals and experts to answer their fact-based questions, or to help them process their emotional reaction to this news. And your genetic counselor and other healthcare providers are there to support you throughout this process. I did want to say a quick comment about instances where people decide not to share genetic testing results with relatives. And I think I'll start out by saying that extenuating circumstances certainly do exist where it's just not possible or advisable to share genetic testing results. For example, if a person is adopted, they may have no knowledge of their biological relatives. And so, of course, they're not able to share this information. Or another circumstance might be that in some situations, it's just not advisable or safe to share this information with family members. And there certainly are other extenuating circumstances that I did not include on this slide. But overall, I think these extenuating circumstances aside, when there is the opportunity to communicate results and share this information with relatives, from a genetic counseling perspective, it would be something that we would suggest, mainly because, as we've said before, this information really may allow your relatives access to earlier cancer detection or cancer prevention. And so with this, keeping this information from biological relatives will unfortunately not change their risk for cancer, but it could limit their options for early detection and prevention, as I said. Ultimately, though, genetic testing is your health information and thus your choice to share. Sometimes we get questions about communicating results to children or talking with children about a cancer risk in the family or about a gene mutation. So sometimes we get questions asking, when should my child have genetic testing, or how do I have this conversation with them? And I'll start out by saying that cancer genetic testing is generally not recommended in childhood, though rare exceptions do occur. As we had said previously, many of the hereditary cancer conditions that we're able to test for are associated with an adult onset risk for cancer. So that risk in childhood just really isn't there at a significantly increased level. And so through this lens, I think in many cases, it's just unnecessary to think about genetic testing for children. And I think kind of beyond that, thinking about testing a child for an adult onset cancer condition, results for children also may just not be actionable. And so there may be no screening that would be recommended for that child if they do test in childhood for years or even decades to come. And so this brings up the issue or the concern of, are we causing psychological harm to that child or to that family by performing genetic testing so early when there's really nothing that can be done, to use a manner of speaking? And along these same lines, when we think about testing children for adult onset cancer conditions, another issue or concern that comes to mind is wanting to respect the future autonomy of the child. So autonomy in this situation, meaning that child's right to make the decision, do they want genetic testing? Do they want to know this information? When do they want to know this information? And I think this decision of when is right to test a child for a hereditary cancer condition is a very complex conversation, and there's certainly never a one-size-fits-all answer. I think each family in each case really needs to be taken on an individual basis. And so if you have questions about this for your family, please reach out to your genetic counselor, your healthcare team, and they may be able to have the conversation with you about the pros and cons of testing for these hereditary cancer conditions at different stages in life. And although we don't always recommend genetic testing in childhood, it certainly is okay to talk about hereditary cancer risks in childhood. And there's really no right or wrong way to have this conversation and no right or wrong age to have this conversation. All families are unique and you know your child best. In terms of how to have this conversation with young children, I think many experts would say that you don't need to have this conversation all at once. So it can be helpful to just to kind of break this conversation up into smaller sound bites. Along with this, it's also helpful to use age-appropriate language with children and avoid euphemisms, as euphemisms, especially for children, can cause confusion. And in doing all of this, you can model to your child or the child in your life that it's okay to talk about hereditary cancer risks. And that might encourage them to ask questions when they're ready and lead to more open lines of communication. In terms of when to have this conversation with children, so when to tell them of a hereditary cancer risk or a gene mutation in a family, there's some data that says that half of all parents tell children within a month of receiving their test results. But again, you have to decide when you're ready to have this conversation and when your child is ready to have this conversation. And as I had said before, from a medical standpoint, it's important to disclose this information prior to an age when medical recommendations would change. Based on the gene mutation that you have or the gene mutation in your family, speaking with a genetic counselor and figuring out when would screening, specialized screening be recommended to begin? Is it in adulthood? Is it in childhood? Is it when someone's in their 20s, their teens? Knowing this information can help your team as a whole, help you decide when should we disclose this information, when is the right time. So if you have questions about this, please reach out to your genetic counselor. I did want to include some genetic counseling and testing resources. Here at Mass General in the Center for Cancer Risk Assessment, we're certainly happy to meet with families and patients to discuss the opportunity to move forward with genetic testing or existing genetic testing results, and I've included our number here. For folks who may be looking for a genetic counselor, maybe not in the Boston area, but elsewhere in the country, it can be helpful for them to reach out to their primary care provider, as their primary care provider can usually place a referral to a cancer genetic counselor. Another resource for locating genetic counselors is to check with local cancer centers, as they either often staff genetic counselors or they have access to them. There is also an organization and website, the National Society of Genetic Counselors, that has a Find a Genetic Counselor tool on the website. So you can put in your location in the country or the location of your family member, and you can search for local genetic counselors. And then there are some independent national genetic counseling services that I've listed here, Inform DNA and Genome Medical, to include a few. And then in terms of some additional support resources, first and foremost, I've listed KinTalk, which we mentioned on a prior slide, so I won't speak more to that here. I did want to specifically point out an incredible organization called FORCE, which stands for Facing Our Risk of Cancer Empowered. This is an organization that promotes education, support, advocacy, and research efforts for hereditary cancer families. One of their many offerings is that they do have local support groups in different areas around the country. And for those in the Boston area, the upcoming support group is virtual, and it's on February 2nd, 2022 at 6 p.m. And one of the leaders who helps to facilitate this support group is Margaret Emmett, and she's one of the genetic counselors in the Center for Cancer Risk Assessment here at Mass General. And then very briefly, for folks who are looking for more resources to discuss hereditary cancer risks of children, I did want to call out a booklet that was published by FORCE and in conjunction with the National Society of Genetic Counselors, called Talking About BRCA in Your Family Tree. Although this booklet was primarily designed for families where there's either a BRCA1 or BRCA2 gene mutation, I think that the themes that run through this booklet are widely applicable to any hereditary cancer family. And for those patients here at MGH offers something called the PACT program, which stands for Parenting at a Challenging Time. This was initially developed as a consult service for parents or caregivers who they themselves received a cancer diagnosis. And patients would then meet with professionals to discuss how to talk about cancer in a family and also topics surrounding childhood resiliency. For folks who either are or are not at MGH, there are many free resources on the website that I think are really widely applicable, not just to that specific population. So it might be worthwhile to look into those. And at this point, I will wrap up. I've included a picture of our team here, and thank you for the invitation to speak today. And if there's any time, I can take questions.
Thank you very much, Kathleen. We do have a couple questions that I think we can get to briefly. The first one being, I had genetic testing based on a family history of pancreatic cancer a number of years ago. How often should I be doing updated testing, if ever?
That's a good question. I can't speak to your specific situation, but I think checking in with your genetic counselor once in a while is certainly reasonable. I think for some people, they had genetic testing long ago that the technology has actually drastically changed. And so checking in every few years might be reasonable. We've also learned of many, many new genes that are associated with hereditary pancreatic cancer. And so it's possible that you have not had what we would consider sort of standard or complete testing. I think another reason that you may want to consider checking in with your genetic counselor is if your family history of cancer or your personal history of cancer has changed. If there are significant changes in the personal or family history, we may think about offering expanded testing that's sort of tailored towards your new history. And then checking in with your genetic counselor can also be helpful because there may be updated recommendations that exist or updated resources that you could have access to by checking in.
And can you tell us how the saliva or blood test for cancer genetics is different than the genetic test that my oncologist ordered on a tumor sample?
Yes, so those are different tests. I think we spoke about this briefly earlier on. So the saliva or blood test is looking at genes that that were inherited, so genes that you were born with, whereas the test that was ordered by your oncologist is what we call a somatic test. So it's looking more at the cancer genes that exist only in the cancer tumor itself. And we certainly know that the cancer composition of tumor somatic testing is typically very different than what your DNA, the cancer composition of the DNA that you were born with. So they're just very different samples, and the DNA is just not similar. So often we test the two for different purposes.
Great. Thank you very much. I think in the interest of time, we will close the Q&A for now and move on to Dr. Weeks, but thank you very much, Kathleen. And so I just want to update, I know we had a couple questions about Dr. Bardisi's talk, who was right before the break. He has offered to re-record that lecture, so I'm not quite sure on the time frame for that, but we'll get that as soon as possible and then post that to our website with his slides so that you can take a look in the future. But next up, we have Dr. Colin Weeks. Dr. Colin Weeks is our Associate Professor of Medicine at Harvard Medical School and the Director of Medical Oncology Research for Pancreatic Cancer at MGH. Dr. Weeks' research focuses on the targeted therapies and clinical trial development for patients with pancreatic cancer. Today, Dr. Weeks will give us an update on the newest chemotherapy strategies to treat pancreatic cancer. Welcome, and thank you, Dr. Weeks.
All right, I thank the organizers for giving me the opportunity to speak to you today. Today, I'm going to talk about updates in chemotherapy paradigms for the management of pancreas cancer. These are my disclosures. So what I want to start out with just a picture of the pancreas and sort of get some orientation to where it is. And so you can see here that the pancreas sits sort of right inferior to the stomach, and it's sort of right in this pocket of the small intestine. And here you can see a tumor that's in the head of the pancreas. And then this would actually have, if we were to open this up, you'd see the bile duct coming down from the liver through the pancreas head and into the small intestine. So pancreas cancer is the 9th most common cause of cancer in the United States, as demonstrated here. Unfortunately, it is right now the 4th most common cause of cancer-related deaths in the United States, behind prostate cancer and colon cancer in men, and behind breast cancer and colon cancer in women, and then behind lung cancer is the #1 killer. It is predicted that by the end of this current decade, that pancreas cancer will surpass colon cancer as a cause of death in the United States and be the 2nd most common cause of cancer in the United States that's not related to hormonal cancer. So this is really a huge problem for America going forward. And this is demonstrated here. You can see that for almost every cancer besides pancreas cancer, which is here in light blue, the incidence or deaths associated with the disease is going down. However, with pancreas cancer, the deaths are somewhat on the rise. And this is likely due to this sort of complex nature of this disease. So if you look here on the right-hand side, what you're seeing is a histogram of pancreas cancer. And what you can see is predominantly this pink, white area that's really sort of we call stroma, or the support area associated with the tumor. Whereas the actual tumor cells, which is seen here in this and right here, are really small islands within this larger mass. And so the predominance of the cell types within a tumor is really these stromal immune cells, tumor microenvironment components. And this is depicted here on this diagram, where you can see that there's different types of pancreas cancer cells, as well as different components of the stromal and immune components. And then you've got all these additional extracellular matrix components, and then a whole slew of signaling pathways that are responsible for the function of these cells. And so you can imagine that this complex interaction between these different cell types, the extracellular matrix, makes it very complex and difficult to treat this disease. So I show these two slides. So this is demonstrating FOLFIRINOX and the benefit associated with FOLFIRINOX in patients with metastatic disease. And then this part of the slide demonstrates the benefit associated with gemcitabine and Abraxane. But the point to be made here is that these studies were published in 2011 and 2013, so almost a decade ago, and we really have not been able to make much progress beyond these interventions. And so we've taken an approach where we're going to ask sort of what happens to the tumor in the context of chemotherapy exposure, and can we harness those mechanisms by which the tumor uses to escape therapeutic intervention as a therapeutic approach. And so over the course of the past decade, what we've seen is that there's been this molecular characterization of pancreas cancer into different sort of subgroups. And it turns out that these pancreas cancer cells can sort of switch between these subgroups, and I'll show a little bit about that in the upcoming slides. But suffice it to say, there's this classical or subtype A, or this quasi-mesenchymal or subtype B cancer cells, pancreas cancer cells. And in fact, this is now being demonstrated to be clinically relevant. And so patients who have the subtype A pancreas cancer cell, which is shown here in purple, versus those patients who have the subtype B, which is shown here in gold, those patients with the subtype A are the ones that preferentially respond to FOLFIRINOX therapy. And this was shown to actually improve the progression-free survival associated with treatment with FOLFIRINOX. So in other words, those patients who have the subtype A or classical phenotype, those are the patients who preferentially respond to our FOLFIRINOX chemotherapy, and those are the ones that potentially have a clinical survival benefit associated with treatment with FOLFIRINOX therapy. So our group at MGH, one of our investigators named David Ting, has demonstrated that in fact, this is also the case for patients who have localized disease. And so what he showed for patients who have localized pancreas cancer, about 2/3 of those patients have the type A subtype, and about 1/3 of patients have the type B subtype that's predominating their tumor at the time in which they are diagnosed and are untreated. However, once you treat those patients with chemotherapy, in this case FOLFIRINOX, what he observed is that actually there's a switch. And so now 2/3 of the patients now have this predominance of the mesenchymal phenotype or type B, versus only 1/3 of the patients that are having the type A phenotype. And once again, going back to the previous slide, it's these patients who have this type A phenotype, those are the ones that respond to FOLFIRINOX. And so this suggests that as the tumors switch their phenotype with exposure to FOLFIRINOX, this could be a mechanism of acquired resistance. And he's been able to demonstrate this using this, what we call RNA in situ hybridization technique, in which he can look at the genes that are being expressed within the tumors, which are demarcated here in brown, which have the epithelial or subtype A phenotype. And conversely, he can simultaneously detect tumor cells that are expressing these genes that are associated with this subtype B phenotype shown here in pink. And so you can look at the tumor and actually see what proportion of the tumor is subtype A versus subtype B, and what are the localizations and associations with these different tumor cells as they lay in these different subtypes. So what Dr. Ting went on to show is that it turns out that this protein called TGF-beta is important for this switch. And so what he demonstrated is that if you expose tumor cells to FOLFIRINOX, you get an increase in TGF-beta, which is being produced by these stromal cells, and that results in this transition to the type B phenotype or quasi-mesenchymal, and those tumor cells are resistant to FOLFIRINOX. So conversely, if you inhibit the capacity of the stromal cells to produce TGF-beta, then you can maintain this epithelial phenotype as a predominant phenotype, or this type A. And in that case, you retain the sensitivity of these tumor cells to fulvirinox. And so this is what he demonstrated in preclinical models. And now I'll show you how we've tested this hypothesis in the clinic. So we did a couple of clinical trials in patients with locally advanced disease in which we treated them with either fulvirinox, radiation, and then surgery. And then we did a second trial in which we added the drug losartan. So losartan is a blood pressure medicine, and it turns out that losartan inhibits the production of TGF-beta. And so in patients who historically had disease that was not resectable, which is locally advanced, when we added losartan to their chemotherapy regimen, we saw that 2/3 of those patients were able to have their tumor resected or taken out without evidence of tumor at the margins where the tumor was cut out. So this is really a dramatic outcome. And then we asked, okay, if we're able to have those tumors taken out, does that result in a survival benefit for these patients? And so we took those two studies at a 5-year sort of time period. We looked back and we said, okay, what percent of those patients are surviving and what are the factors that underlie that? And what we're able to demonstrate is that of 97 patients treated in these two studies, 66 patients had their tumors resected, 31 did not. If you look at the survival of these patients, the overall survival in months, the patients who had their tumors resected had a 46-month median overall survival versus those patients in which the tumors were unresected, it was a 14-month median overall survival. So really resection is a critical thing. And so if we can get patients to resection, in this case with TGF-beta inhibition with losartan, we can potentially improve outcomes for our patients. And so this then led us to do this next trial, which actually was just completed a couple of weeks ago in terms of enrollment, is to ask the question in a randomized fashion, if we add losartan to fulvirinox therapy in the neoadjuvant setting, can we improve outcomes for these patients? And then in addition, our previous work demonstrated that we see augmentation of the immune system in the tumor in the context of losartan exposure. And so the question was then, can we add nivolumab, which is an immune stimulating agent, to then harness the immune system in addition to the benefits of chemotherapy to improve outcomes for patients. And so this study has now completed enrollment as of about 2 weeks ago. And so now we're waiting for all the patients to complete their therapy. And hopefully in about 6 months from now, we'll be able to answer at least some initial questions in terms of the benefit of this therapy. Now, the cool thing about being at MGH is that we've got all these different investigators who have the capacity to apply different techniques to then understand what's happening to the tumor. And so this is what's called digital spatial transcriptomics. And what it allows us to do is to sort of say, okay, if you look at this area under area of investigation, look at just these cells. Number one, what are the cells comprising this area? So in this case, we're seeing tumor cells, we're seeing immune cells, we're seeing stromal cells as well. And then we can also then ask, okay, what's happening to their RNA production in the context of these different cells being organized in a certain way? And so we can then begin to understand what are the pathways that the tumor cells are using, as well as what are the pathways that the immune cells are using as they engage one another. And how does that change within the tumor depending on sort of where in the tumor do we look? Furthermore, we can also now look at sort of doing liquid biopsies, and in this case, talking about circulating tumor cells. So we know that the tumor cells shed into the bloodstream, and then they are circulating. So can we use, say, the number of those tumor cells in the bloodstream for a volume of blood to understand what is happening to the disease in that context? So in this particular diagram, what we're showing is that we had a patient who had a resectable tumor, and what we saw is that the CA19-9 level was at this value prior to resection, and then after resection, it went down. The circulating tumor cell level here in red was relatively flat at the time around resection. And then what we saw was that the patient had a significant response to chemotherapy, but we saw then that the circulating tumor cell volume started to increase, whereas the CA19-9 came down. And then ultimately, this patient was found to have significant liver metastases. And what you could see is that this trend would have predicted several months earlier that this patient was having ongoing disease refractoriness in comparison to what we saw with CA19-9 levels. And so one of the questions that we're asking is, can we use alternative mechanisms or alternative markers within the bloodstream to assess how our patients are responding to therapy? As we know that the CT scan and right now CA19-9 isn't the best test to ask those questions. An additional step that we're taking is to understand how can we use imaging in a novel way to understand biology. So in this case, what we're looking at is a fibrosis score. And so we know that pancreas tumors are very fibrotic. That extracellular matrix I showed you, that pink stuff I showed you earlier, that makes the tumors very fibrotic. That fibrosis is associated with decreased chemotherapy penetration into the tumor, decreased immune cell penetration into the tumor. And so using MRI techniques, we can ask the question, are we altering fibrosis associated with therapy? And does that alteration of fibrosis impact the outcomes for our patients? And take that one step further, and by using a unique contrast agent for MRIs to ask what happens to the macrophage infiltration associated with therapy. We know that there are subsets of macrophages that are and then there are those that inhibit the immune system in its response to cancer. And so one of the things we want to ask is, number one, what is happening in terms of the infiltration of the macrophages into the tumor associated with therapy? And then number two, what are the actual subtypes of macrophage cells that are in the tumor in this context? So with therapy, are we having an influx of macrophages that promote the anti-tumor immune effect? Or do we have an influx of macrophages that inhibit the anti-tumor immune effect, that influx into the tumor, or efflux? And so taking all of those things together, we've now come up with this trial. And so this trial is adding a specific TGF-beta inhibitor. So now we're sort of removing losartan as a poor man's TGF-beta, which is sort of non-specific, now adding a specific TGF-beta inhibitor to our treatment. And then also in the third arm, adding another drug that targets the immune system. So we're asking, can we specifically overcome historically resistance to immunotherapy by adding TGF-beta plus the PD-1 inhibitor? At the same time, we're going to be able to sort of evaluate our patients both from an imaging technique, as well as our liquid biopsy techniques, as well as our sort of techniques to actually look at the tumor and be able to understand what is happening to the tumor in these different contexts associated with our therapy. And can we then leverage that information then to design further therapies and trials that hopefully will put us in a position to cure patients at some point in the near future. Now, we've also working with some colleagues who have demonstrated that GSK3 beta, also in addition to TGF beta, mediates this transition from subtype A to subtype B associated with chemotherapy exposure. And so we've now designed a study where we're asking if we inhibit either GSK3 beta alone with this drug 9NG41, or TGF beta with losartan, can we improve the outcomes or the survival associated with treating patients with FOLFIRINOX? And do we inhibit the capacity of the tumor cells to go from subtype A to subtype B? And is there any relationship between that process and outcomes for our patients? This is a trial that we're going to be actually opening in the next couple of weeks. This is for patients with untreated metastatic pancreas cancer. So I'm showing this slide to get to another point, but I grew up in Alliance, Nebraska, here on the sort of western side of Nebraska. And I went to medical school here in Omaha. And so, you know, on holidays, I'd have to go back home on the holidays. And so this is a very long drive. So this is about the distance of driving from Boston to Baltimore. And so you can imagine that as a huge undertaking. And so the way I thought about it was, I would drive to Lincoln and then drive to Grand Island and then drive up here to Thedford and then home. So kind of break it up. And I think the same sort of thought process, we have to think about how we treat patients with metastatic disease. So instead of treating patients with drug, FOLFIRINOX until they have disease progression, what if we were actually intelligently changing therapy based upon what are the parameters in which the tumor was using to survive at that time? And so this is a trial design that we're working towards trying to utilize for our patients going forward. And this trial is sort of our first example of such a design. So as you can see here, patients are getting FOLFIRINOX plus losartan or 9-ING. They'll then move on to maintenance therapy. And then if they have progression of disease, they're going to go back onto FOLFIRINOX-based therapy to then try to re-debulk the tumor. And so this is sort of our initial sort of clinical test of this idea. So once again, debulking, maintenance therapy, and then back to debulking therapy. And so this will help us to sort of build some initial data to sort of understand whether this is a plausible approach or not. So shifting gears a little bit, what does the future hold to improve outcomes for our patients? So what this demonstrates is the transition from a normal pancreas duct to frank pancreas cancer. And what we know, if we look at genes associated with that process, we know that upwards of 90, at this point, probably 95, 96% of patients have this KRAS mutation. And we know that KRAS alterations are early parts, so it happens here very early in this process and persists throughout. And so if we could target KRAS, can we ultimately impact the outcomes for our patients? So this particular study that we're doing is actually a vaccine. So this vaccine recognizes mutant KRAS. And so here we're sort of saying in patients who have really low burden of disease, if we expose them to the vaccine, can we now stimulate their immune system to then recognize these alterations, these cells with these alterations in RAS, and therefore use the immune system as our therapy based upon the fact that the tumors have this RAS mutation. If we take that sort of one step further, we now have been able to demonstrate that if you inhibit RAS, the cell then sort of gets stunned. And when it gets stunned, it uses this pathway called autophagy. And autophagy allows the cell to sort of use its own components for fuel in the situation where it's been stunned and hurt. Now, if the cell's able to overcome whatever that insult is that resulted in being stunned, then they'll go back into normal function. However, if the cell's not able to overcome that, then the cell will die. And so what this series of papers demonstrate is that if you inhibit the RAS pathway in some way, and you also inhibit this pathway of autophagy, then the cells can't overcome that insult and then they die. So there's a number of trials open here at MGH as well as other places across the country trying to ask this question. And then most recently, it's been demonstrated, this DCC3116 is a selective inhibitor of this gene called ULK. ULK is sort of the initiating process associated with autophagy. So this is a specific autophagy inhibitor, which autophagy has been demonstrated, as I just said, to be important for pancreas cancer biology. It also works in other ways within pancreas cancer. And so hopefully this drug will give us a novel approach to targeting pancreas cancer and some of the biologic principles that are associated with pancreas cancer, both development as well as growth. And this is just the study design in which we're showing that patients, it's a first-in-human study, first-in-class study that we're doing at MGH, so a very unique opportunity for our patients. And so with that, I'd like to thank you for your time. This work would not be possible without the incredible team of both clinical investigators as well as laboratory investigators that I get to work with. And so with that, I thank you, and I will take any questions that you may have.
Thank you very much. So thank you for your time. Just in the interest of moving forward, I think we will start to wrap things up, but certainly if there are any last questions, feel free to put them in the Q&A. Before I toss this back over to Dr. Chung to wrap things up, I just want to remind everyone that there will be a survey going out to all attendees. We appreciate all of the feedback that you have. We of course try to improve our meeting every year. So any thoughts, ideas for new topics, ways we can improve, please let us know. But with that, I will toss it over to Dr. Chung.
Hi. I don't know, can you hear me okay?
We can hear you.
All right, okay, great. So so I will just echo my thoughts to thank all of you for attending. I apologize for some of the AV and technical issues we had. We have our faculty, unfortunately, is kind of very busy and pulled in many directions. And so I'm sorry that we were not able to provide the optimal recording settings, but we will work to get re-recorded lectures for you. So those will be available on our website at a later date. You know, pancreas cancer is something that has become more and more, we recognize more and more important, has always been a challenge, but I think there's so many exciting developments in terms of research of how we treat, of how we potentially can diagnose early, and how we recognize people who are at high risk. And so, you know, our program is really dedicated and devoted to really moving forward in all of these directions. And we're just thrilled to be able to share some of our insights and what we've learned and where we're going with you. If there are any questions still remaining, I'm happy to answer them for you. There are a couple of remaining questions here from the Q&A. There was one about whether glucose feeds a pancreas tumor, and I will just that is a great question that I think a lot of people ask, you know, because there is a lot of interest in how metabolism of tumors is quite different and whether high sugar makes a difference in someone's diet. So I think the only thing we can say there is that yes, tumors metabolize sugars quite differently, and many of them really are dependent on things like glucose. Whether like a diet that's high in glucose actually translates to increased growth or risk, I think is a little uncertain. I think that there's probably no harm in someone, you know, adopting kind of a low carb diet while they're in treatment, but it, you know, the notion that you could reduce any exposure to glucose to these tumors is probably kind of unrealistic, just the way that the body normally works. So there's probably no harm in that, but I think that we don't really know the answer specifically about what that means for someone's diet while on treatment. How do you know if a BRCA patient responds to olaparib? So that is something I should probably defer that to Dr. Weeks as a medical oncologist. I mean, I think as you all know, yes, there is a lot of interest in use of PARP inhibitors in people who have some of these specific gene mutations. You know, I think that we're excited that there can be such sort of targeted approaches to treatment based on underlying genotype. But I do think that in general, the responses to treatment are going to be kind of the conventional measures that we use for in terms of tumor responses, in terms of either tumor markers or imaging studies, and things like that. I'm not sure that there are specific markers that are used when we treat BRCA patients with olaparib. If I just will reiterate Linda's final comment about we would love your feedback. We have been doing this annually for the past 5 years. We hope to keep doing this. And so we do respond to your questions, concerns, interests. So if there are specific topics that are of interest, please let us know because we would like to tailor it, because this is designed for all of you. We want to be able to give you the information that you're seeking out. So with that then, I want to thank all of you again for attending, and I want to thank all of our counselors and staff who've really put a great deal of time in trying to make this work. One of these days, we hopefully will have it as an in-person conference again. And if you all want to just hang on the line just a little bit, we can see if Dr. Weeks can answer some of those questions via text, okay? So thank you very, very much. And Colin, if you can hear me, if you could try to respond to some of those Q&As directly by text would be great. All right, so thank you again.